today's DCRI Research Conference. Today we have a distinguished speaker, and it's a real pleasure to introduce Dr. Bernard Gersh, who many of you have had the pleasure of spending some time with during his visit here to Duke. Dr. Gersh is a professor of medicine at Mayo Clinic and a consultant in cardiovascular disease and internal medicine. His past positions include the W. Proctor Harvey Teaching Professor of Cardiology and Chief of the Division of Cardiology at Georgetown. He's also, prior to that, he has had numerous other leadership positions, but he started his professional career at the University of Cape Town, where he received his MB CHB, and then was a Rhodes Scholar at Oxford University, where he earned his Doctor of Philosophy. He has a broad range of cardiovascular disease interests that range from the natural history of therapy of acute coronary syndromes and electrophysiology related disorders related to atrial fibrillation, sudden cardiac death, syncope, as well as cardiac stem cell therapy and the epidemiology of cardiovascular disease in the developing world. He's widely published with almost 800 publications, over 100 book chapters, is the editor of 14 books, and is on the editorial board of 25 journals. Among his other numerous accomplishments include a number of honors, including the 2004 recipient of the Distinguished Achievement Award of the AHA Council of Clinical Cardiology, and the 2007 recipient of the ACC Distinguished Service Award. He's been a national and international leader on a number of well-known trials, and today we'll hear from a very interesting and potentially controversial trial. Wonderful to have the insights of Dr. Gersh.
Thank you.
Join me in welcoming him.
Thanks very much. Thank you. Thank you. And as always, it's a great pleasure to be here. As I mentioned yesterday, I've had the chance, and it's been very interesting to, let me just get this up, to be a bit player in two really interesting trials, namely SYMPLICITY and Improve It, which some of you heard about yesterday. And so my role with SYMPLICITY was to chair the DSMB, and it's been a very interesting experience. Let me just do this. So the physiology behind renal denervation is pretty well established. And this article from Murray Esler in Melbourne states it very clearly. Evidence has been assembled in the past 3 decades which indicates that the sympathetic nervous system is crucial to the development of a number of cardiovascular disorders, namely heart failure and essential hypertension. And then there's the classic paper by Smithick of a complete sympathectomy, which was published, I think, in 1953. And it should be remembered that this surgical paper actually demonstrated not only a marked reduction in blood pressure, but a reduction in mortality. At that time, of course, there was no pharmacologic therapy available really that was effective for hypertension. But there was a mortality reduction, but the side effects were unacceptable in terms of orthostatic hypertension, amongst others. This review illustrates and summarizes the effects of the increased sympathetic nerve activity on 3 renal nerve effectors. The first is the juxtaglomerular granular cells. The results of sympathetic nervous hyperactivity increase the rate of renin secretion through the beta-1 adrenergic receptors. On the renal tubules, there's increased renal tubular sodium reabsorption and reduced urinary sodium excretion, which can clearly be pathophysiologically related to hypertension. And then there's a reduction in renal blood flow. And all of these 3 factors can interact and are part of the pathophysiology of hypertension. This animal study from the University of Minnesota pointed out that obesity-induced hypertension in dogs appears to be due in part to increased renal sympathetic activity. And in this study of dogs undergoing renal denervation, you can see these are daily blood pressure recordings averaged over a number of animals, a significant reduction in hypertension in these dogs after renal denervation, which occurred here. And what is also interesting is to see the correlation in the reduction in systolic blood pressure down here with renal tissue norepinephrine content. And the lower the renal norepinephrine content, the greater the reduction in blood pressure. So I think there's a very sound pathophysiological basis for the sympathetic nervous system as a target in hypertension. And then there were the trials, multiple unblinded trials, including SYMPLICITY-1 and 2 and a large registry study, really showed staggering drops in blood pressure, 25 millimeters of mercury. And these are the Medtronic trials in yellow, and these are from other companies. And I might add, my only conflict is as a member of the DSMB of this trial, and this was supported by the CRF Foundation and not Medtronic. The trial was, but not my role. And here again, from a number of different catheters, an average drop in blood pressure of 30 millimeters of mercury, which from an epidemiological perspective is huge. And then I wrote this review about 3 years ago with Ong Myatt, who's a fellow at St. Thomas's, and co-authors of Brian Williams, who has done an awful lot of work on hypertension in the UK, and Deepak Bhatt, who's the PI, joint PI of SYMPLICITY-3. And I was very relieved to go back and look at this, when the trial came out, to go back and look at this review that was written about 6 months before we started the trial. And fortunately, we did say this. The SYMPLICITY Hypertension 3 study is critically important because it'll provide the first truly controlled assessment of this technique and will minimize confounding from expectations and evaluation bias, respectively. I was very relieved to see that, actually. And it was important because we did point out we've got all these trials, staggering results, but we need blinding. And these are the results. And this is from a paper published. Most of the work was done by Stuart Pocock in JACC recently on clinical trials and their relationship to society's needs. And these are the first two trials. SYMPLICITY-1, denervation alone, reduction in blood pressure about 25 millimeters. SYMPLICITY-2 with an unblinded control group shown here, and denervation, unblinded control group, almost no change in blood pressure. Denervation, 30 millimeter drop in blood pressure, and then SYMPLICITY-3. And I have to tell you, I can remember about 2 years ago when we first saw the first cut of data. And most of the other members of the DSMB were eminent nephrologists and hypertension physicians. And we were stunned. I mean, there was nothing there. There was nothing there. There was a significant drop in blood pressure, but as you can see in both groups. And so in this sham-controlled trial with a sham procedure, denervation about 15 millimeter drop in blood pressure, and in sham controls an 11 millimeter drop, nowhere near significance. And we were amazed. We also kept a secret because this was 2 years ago. And the first leak of the results of this trial came out on a Sunday early in January this year when I got a call from Medtronic saying, we've now finished the trial and seen the data. And I said, has it changed since last September? And they said no. So our first cut of the data persisted throughout. And this was the difference, the sham control versus the unblinded controls. At the same time as the trial came out, Michelle Bohm from Germany presented the Global SYMPLICITY Registry. This was the follow-up on 751 patients. And here in the registry was the reduction in office systolic blood pressure. This is with denervation, 12 millimeters on an average. In the group with the highest systolic blood pressure is 21 millimeters. And compare it with the trial, there's absolutely no difference, really. If you look at the control in the trial and the control in the registry, and at least control in the trial and denervated in the registry, it's almost identical. And this was the trial denervated group, 14.1 millimeters. So we have this interesting group here with the highest blood pressure at baseline, and I'll come back to that. And Bohm did mention in his presentation that, of course, they don't have a sham control group in the registry. So viewpoints really differed, as all good trials generate polarized opinions. I think Stuart and I are a little unfair and maybe a little simplistic. We said the story thus far indicates that the type of an illusory breakthrough in the management of resistant hypertension, only an Englishman could say that. That's his term. Illusory management of resistant hypertension was perpetuated by inadequately designed randomized control trials, which gave exaggerated findings and did not take into account the power of the placebo. The Europeans took a different attitude. Schneider, who's president of the European Society of Hypertension, says, we continue to support renal denervation as a treatment option for selected patients with drug-resistant severe hypertension. And then the European Society of Hypertension, he's the spokesman, sticks to its statement from 2013 on the use of renal denervation in appropriate patients with drug-resistant hypertension. So there's a considerable amount of polarization. I love this quote from President Bush. I have opinions of my own, strong opinions, but I don't always agree with it. So maybe Stuart and I were at one end of the spectrum and the Europeans at another, but needless to say, this trial has generated a great deal of interest. And I think it reflects this a little bit. All evolving therapies, remember drug-eluting stents, progress, excitement, euphoria, then you get a reality check, then everybody's depressed, and then you come back and place things into perspective. And this has happened with drug-eluting stents, it's happened with stem cells, it happens with so many things. And I think we can say that the initial enthusiasm has been tempered, and the number of unanswered questions is not decreasing. But I will try and convince you that the field still maintains its promise, and I'll try and explain why in the remainder of this talk. So the explanations of this. Was it the wrong catheter? Were they the wrong operators? What about the power of placebo? The role of compliance? And you have the world expert here in Mrs. Granger, Brady Granger, on drug adherence, regression to the mean, and the fact that these trials used office BP, which is a bit more subjective than ambulatory BP. At least the prior trials did, not SYMPLICITY-3. And I want to take you through each of these potential explanations. I also like Huxley's quote, the idea might yet prove to be another beautiful hypothesis, slain by ugly facts. Well, what about the placebo? As you say, this says as effective as the leading homeopathic treatment. You have to believe in it to experience the benefit, but I still do like Brady's paper, and wonderful paper on those people who didn't adhere to the placebo did worse than those who did. So the power is real. Mark Twain says, the power which a man's imagination has over his body to heal will make it sick as a force which none of us are born without. The first man had it, the last one will possess it. And there's a wonderful story about Mark Twain in this book called Drugs and Behavior. He apparently had difficulty sleeping in poorly ventilated rooms. He found himself in a small hotel room with a window that was stuck shut. He tried in vain to fall asleep. Finally, unable to bear it any longer, he reached under his bed, picked up a shoe, and heaved it at the window, and then the ensuing crash relieved him, and he had a beautiful night's sleep. And when he woke up the next morning refreshed, he found that he'd missed the window and he'd shuttered him around the bathroom. So this isn't a nice example of a placebo, what is. And this is another very interesting study that illustrates the power of the mind. Now, apparently, amongst Chinese and Japanese, the number 4 is unlucky, whereas it's not for white Americans. And this study was to determine whether cardiac mortality was abnormally high on days considered unlucky. And it took place in LA, coroner's office, examination of cardiac and non-cardiac mortality on and around the 4th of each month in Chinese and Japanese subjects and white controls. And if you look at the data, you'll see that on the 4th of the month in Chinese and Japanese, there is a peak in deaths, which is not there in whites. Now, I caution you about this because the date of this article is the 25th of December. And the British Medical Journal on the 24th or 23rd of December always publishes 3 or 4 articles that are incredibly funny and incredibly clever, and when you read them, you're still not sure whether the whole article is in jest or not. They're so well written. So I probably wouldn't believe this. I think it probably is made up. But here is a great example of emotion and the power of the placebo. Now, neurocardiogenic syncope, which has long been an interest of mine, is a fascinating condition because it is neurocardiogenic, and the brain has a big role to play. Now, these were 4 trials of active pacing versus medical therapy in neurocardiogenic syncope. And if you look at the pooled data here, the odds ratio is 0.08, a 92% reduction in recurrent syncope favoring treatment with pacemakers. The next few trials, they all had a pacemaker, but they were blinded as to whether the pacemaker was activated or not. And look at the results. If anything, the trend is in the wrong direction, and there is no significant difference. So this is a condition in which the neurologic or the cerebral component plays a role, and I think emphasizes clearly the potential power of the placebo. Now, what about the other explanation, regression to the mean? And this is the Sports Illustrated jinx, and that is a player or a team that is likely to be on the cover of Sports Illustrated. It's because of a spectacularly good performance. Either they were lucky or they were absolutely at the top of their game, and that's why they got there. And so the direction, the likely direction, is downwards. And in fact, a player or a team on the cover is more likely than not to have a disappointing year the following season, or even a disappointing game the following week. And that's really my understanding of regression to the mean, and I thank Stuart Pocock for this. And in medicine, regression to the mean really suggests that if symptoms are excessively severe this week, then next week they should be less severe simply due to random fluctuations. And if treatment is only sought when these symptoms are at their worst, there may be a coincidental recovery. And some people believe quite strongly in the concept. And I think it took place in this trial, and I'll tell you why in this slide. Here is the change in office systolic blood pressure by tertiles of baseline office blood pressure, and less than 170, 170 to 84, and greater than 184. And the greatest reduction in both groups is in those who had the highest blood pressure to begin with. And that was there in that registry study, the global registry that Michael Bohm published. They had a 21 millimeter drop in blood pressure in those whose resting blood pressure was greater than 180. So I think regression to the mean in a condition like hypertension probably really does play a role. The higher the baseline blood pressures, greater the decline with denervation or control is this regression to the mean, and it may be to some extent. A third factor is the role of pharmacology, and Michael Brown in Morris Brown in the UK wrote this rather nice article. Is it resistant hypertension? Is it resistance to treatment or resistance to taking treatment? And Brown Williams's group did this beautiful study looking at rates of non-adherence to antihypertensive treatment by measuring the drugs with high-performance liquid chromatography in the urine. And here are the number of drugs a patient is taking, and in orange is the proportion that are not adherent. So if you take people with resistant hypertension on 3 drugs, you would estimate that somewhere between 25 to 35% are non-adherent. And when they took this study further and looked at those who'd been referred for renal denervation, 34% of them were not adherent. People with hypertension don't take their drugs. It is extraordinary. And in fact, what is being done at Mayo, as soon as this is suspected, the patients come in the morning, we give them their drugs, or the hypertension clinic gives them their drugs, and then the blood pressure is measured that afternoon. But it is an extraordinary phenomenon. They don't take them. And this may have played a role in this trial, because the trial has been criticized because during the 6 months of follow-up, 39% in both arms underwent a change in medications, and in more than 2/3, these were driven by, quote, medical necessity, And the question is, was this because of a fall in blood pressure or uncontrolled blood pressure or side effects? And the vast majority of the changes in medication were due to side effects in both groups. Now, that's not a criticism of the trial. It's not a valid criticism. I think that's clinical medicine. But it certainly plays a potentially important role in the design of future trials. Because we all agree that a pharmacologic approach is better than an invasive approach, although I have to say renal denervation is safe, that's for sure. There's very, very few complications. But from a clinical trial perspective, if we test this device or intervention in a pharmacologically controlled population, a well-treated population, how are we really going to assess the magnitude of the effect of denervation alone? And that may have played a role in this trial, the fact that people took their drugs and were well controlled. Well, you may say that that's all we need. I mean, if they're well controlled pharmacologically, why look for an alternative? But I'm not sure if I wasn't faced with 30 years of 3 drugs that I wouldn't take denervation if it worked. And I believe that the multiple drug combinations may have influenced results. But the question is this: can we test renal denervation ethically in a sham-controlled trial after a period of washout, drug washout? And this was the subject of an American Society of Hypertension FDA meeting in 2014. And opinions were split. Our IRB at Mayo would agree to this. They will agree in people, obviously, with mild to moderate hypertension to a period of drug washout and a trial lasting 6 months. They would agree to it. Other IRBs may not. Obviously, you can't do it with people with severe hypertension. But this, to my mind, is an absolutely fascinating topic. And I think the way to do this is to find people with relatively mild hypertension, mild to moderate, and test the procedure without drugs. And then if the procedure is effective, we then design the next lot of trials versus drug therapy. This is another criticism, that the magnitude of blood pressure reduction in the sham arm of African Americans was very large. They had an average fall of 18 millimeters versus 8.6 millimeters in non-African Americans. We don't have an explanation. There's a subset analysis of those on vasodilator drugs. What's the overall impact on the trial? I don't think it has any impact. I think that's just fishing for excuses to rubbish a trial that doesn't come up with the results that your preconceived opinions felt it should have come up with. I don't really, I mean, here it is. It's nowhere near significant. This is African Americans, and this is non-African Americans. And I don't think that's a fact, although it gets tossed about and was thrown about a lot at the PCR meeting. Now, this is an issue, the technical limitations. I think there is evidence that the dose of renal denervation was insufficient to accomplish meaningful sympathetic denervation, that the ablations were not extensive enough, they were not circumferential enough, and I'll show you why distal versus proximal may be important. There are now new catheter electrodes. Prior to SYMPLICITY-HTN 3 being presented, I believe there were 60 catheter companies. And what was fascinating for me was at TCT, not this year, but last year, I went to the renal denervation session. It was packed. There were about 500 people there, and I sat at the back end of the room because obviously I knew the data, and I didn't want to say anything. No one raised the question that maybe the trial would be neutral. And in fact, one of the most interesting presentations was a guy who went one further. He said, instead of denervating the kidney, he was going to stimulate the bladder. And he showed how that controlled hypertension, and someone got up and said, you know, I'd much rather have hypertension than have my bladder neck stimulated. But this is the Medtronic catheter. There are now other catheters out there, and I think they need to be tested. But equally, we will have to relook at the safety because these are new devices. Now, this is an issue, what the catheter that was used and the experience of the operators. Now, one has to point out that the catheter used was the same catheter as was used in the earlier SYMPLICITY trials. It's exactly the same device. But operator inexperience in the US, 111 operators performed more than one or more procedures and 364 patients, and only 31%, in 31% only one procedure was performed. And I was at the Baker Institute in Australia where Dr. Baker, where Murray Esler works, and they were very, very critical of this. 25 operators, 26 in all, 5 or more procedures. And our own interventionist who participated in the trial really felt that the industry reps that were there in the cath lab during the trial were very, very conservative. I mean, he himself said he feels there were times when he wanted to do more, but I think they were very concerned about safety. I suppose you can also ask the question, I mean, what was the experience of the operators in the very early trials? Someone had to start somewhere. But most people say that in Europe and in Australia, where this had its birth, that really the average operator was much more experienced. And this is a valid question. And I think it is generally accepted that the technical issues now are not to be discounted in the results of this trial. This is a slide from Deepak Bhatt that has been presented. So shown here are the changes in office blood pressure through the first 12 months of the procedure. Now, the trial lasted for 6 months. At the end of 6 months, you could cross over and become denervated, which was a nice ethical way of doing this trial. And this was the 12-month data. But if you look at the people who crossed over from medical therapy to renal denervation at 6 months, the results were exactly the same as they were in those that were treated in the first 6 months. And Dr. Deepak feels that by this time, most of the operators were more experienced. So that's a counter-argument. But I think operator inexperience is a factor that is not going to go away. And this is also an analysis that was presented at EuroPCR, but it's now been published, I think, online in the European Heart Journal. So the protocol talked about 4 to 6 ablations per side, and the synthesis of the data showed that 8 ablations, namely 4 per side, was only present in approximately 50%. And in this post hoc subset analysis, if you look at the sham group, this is at least these are the data in the sham group, but in the denervation group, who actually did get the ablations, there appears to be a significant increase in the drop in blood pressure vis-a-vis the number of ablations. And what they had to do for the sham group, I think, was impute it because they didn't actually have an ablation. So some data suggesting, making the case at least post hoc, that the more ablations you had and the more effective the procedure. And this is also data from presented at TCT by Deepak Bhatt in terms of circumferential ablation. Yellow is 0 4-quadrant ablations, the quadrants being superior, inferior, and 2 posterior. Orange, 1 4-quadrant ablation, and in green, 2 or more 4-quadrant ablations. And there does appear to be a relationship. This is the renal denervation harmony, obviously, in ambulatory, home, and office blood pressures, the more circumferential the ablation, and this includes the crossovers, and you see the same relationship. Now, this is an interesting study published earlier this year that illustrates the periarterial nerve location in the renal vessels. So if you look proximally, and you look at the renal artery here, you will see that the density of the nerves, these being nerves, is greater. There are more renal nerves proximally than in distally, But distally, the distance between the nerves and the lumen is much smaller. It is much narrower. There's much more dispersion of nerve supply proximally than there is distally. And there is the hypothesis, I think, that to do an adequate renal ablation, one has to go much more distally and perhaps even include the branch points. And this is a fascinating but rather sad case of a woman who in Holland, a 36-year-old woman with severe hypertension, who died 12 days of an unrelated cause. She actually had a thoracic dissection after renal denervation using a Medtronic Simplicity catheter. No renal artery dissection, but a thoracic dissection was thought to be unrelated. And in this stain here, this, I don't know which, this is the histology, I don't remember what the stain is, but this is a renal artery. And the dense staining here is an intact renal nerve, at least. This is a partial lesion, and this is a completely denervated lesion. All of these are nerves, but the intensity of the staining reflects the how intact the nerve is. And what you can see is in the area of the probe, which is here, in fact, she's only been partially denervated. This is full denervation, and this is not. And further histology demonstrated a plaque in the renal artery, an atherosclerotic plaque, and the distance from the lumen to the nerve was actually 3 millimeters or more. So I think evidence that renal artery denervation may not have been achieved in many cases. Now, obviously, Dr. Esler's got a lifetime interest in this condition and has come out with this review that is very, very strong. Recently presented results from the Simplicity Hypertension 3 trialists confirmed that renal denervation was not effectively or consistently achieved in the trial. And he may be right and he may not be right. What I didn't like was I was the one bringing the bad news to the Baker Institute, and I said, I didn't do the trial, I just sat in the DSMB, don't blame me. But this is a viewpoint that is held by many. Now, there are a couple of other trials. This is a French trial not yet published, 1,000 patients screened, no sham procedure, 50 patients renal denervation, 50 patients medical therapy alone. Outcomes, nothing. No reduction in office or home BP. And this was not sham, not a sham procedure. But it did use the same catheter, and my understanding is these were experienced operators from France, where they've done this technique for a long time. And this German trial from Leipzig of patients with mildly resistant hypertension, BP 135 to 149 on 3 or more medications with a sham procedure, presented at TCT, change in systolic blood pressure and ambulatory monitoring, absolutely no significance. And then they did an analysis per treatment received, and it's weakly significant. It's a small trial, but the questions still remain out there. The other areas that are interesting are arrhythmogenic. These are 2 studies on 80 patients with atrial fibrillation and moderate or severe resistant hypertension. And this is the recurrence of atrial fibrillation with pulmonary vein isolation and ablation and denervation versus pulmonary vein isolation alone. A significant reduction in the freedom from atrial fibrillation in the denervation group. Having said that, our EP people have been part of a trial that's been stopped. I'm not sure the reasons for it, but it's not stopped for efficacy. It has been stopped. And this is another area of interest. Now, as you know, I spend quite a lot of my time in EP, and there's no question that VT storm is sympathetically mediated. I mean, the mainstay of treatment for VT storm is high-dose beta blockers. And this is a nice case report in the Heart Rhythm Journal of 4 patients with cardiomyopathies. And shown here, these are the 4 patients in each of the colors. This is the frequency of VT episodes, and this is after renal denervation. And you can see a marked reduction in the frequency. And this makes sense. Now, how long that will last for, I don't know. But it makes sense, and it does raise the question of other applications. So to conclude, where are we going to go? And this is a statement from Bram Zuckerman of the FDA. And it's kind of an example of official speak, non-speak. I asked him, and he said, we cannot technically mandate use of a sham control. But given the present knowledge and uncertainties in this field, it would be highly advantageous to utilize best clinical trial science in this area to maximize their chance of approval, and that includes sham control. So that's having your cake and eating it, really. But this is what all the trials will, and appropriately so, have a sham control procedure. It doesn't completely eliminate the placebo effect because 50% of people still think they're getting the treatment, but it's a step forward. And this is from an interesting blog that talks about blinding. Maybe you can go too far. Double blind, as you know, is a more stringent method where neither the subject nor the persons conducting the experiment know which persons are experimentals and which are controls. But then they add, as an aside, it's useful that someone should know or have scribbled down somewhere who is in which group, or otherwise analyzing the results can be difficult. Triple blinding, as in double blind, but in addition, those that request the study for reading do not know if they're reading it or a dummy study, which while outwardly scientific is subtly flawed so that it contains no actual useful results at all. And then probably the perfect form of blinding is quadruple blinding. It's a very unusual method. There are 4 key groups. They're kept in the dark until all the pertinent persons that were involved with the experiment are dead. And then all the uncomfortable and shameful details of the study can be revealed without anyone's livelihood being ruined, never mind the reputation. So we will see blinded trials. This trial is a pilot study. I know Mayo's going to go into it if it's approved. It's a multi-center, single-blind, randomized controlled pilot study. And this is interesting. 4 weeks washout of antihypertensive therapy. Really interesting trial. Our nephrologists are very keen to get into this. And the usual sort of endpoints. It'll be 100 subjects randomized to procedure or sham control, but it will be a single-blind trial. So I think this is a huge step forward, honestly. I'm very excited that our IRB, apparently, our chief of hypertension, Gary Schwartz, has served a long time on our IRB, and he's very confident that we'll get approval. So conclusions, I think renal denervation is still worthy of investigation for resistant hypertension and other disease states characterized by sympathetic overactivity. I do think that to think that renal denervation will cure a disease as a result of lifestyle as complex as metabolic syndrome is wishful thinking. I just don't believe that's going to work, but it might work in VT storm and other conditions. But to think it's going to cure everything from sleep apnea to metabolic syndrome is just, I think, hyperbole. Technical innovations may yet prove to be useful. Resistant hypertension is certainly amenable to expert pharmacological control. The question is whether renal denervation will turn out to be a worthy alternative. And we clearly need additional trials that must be randomized, blinded, and have controls, sham controls. So this is courtesy of Gary Schwartz and why I think people are still excited. This is a patient who went into the SYMPLICITY trial. 62-year-old farmer with type 2 diabetes, obese, baseline meds, olmesartan, amlodipine, furosemide, guanfacine, and a clonidine patch. He was randomized to denervation. And Schwartz is adamant that he was taking his drugs. They were being administered under monitored conditions in the clinic. And here is his baseline blood pressure, awake, asleep, 24 hours, 180/93. 1 month after denervation, 3 months after denervation, now his medications are reduced, 6 months afterwards, and 12 months afterwards. And the update on this now is 18 months later. He has controlled hypertension. So there are people out there that really may benefit. And this is just one case, but it's pretty impressive. Again, is it the power of the placebo? I mean, he knew there was a 50% chance he would get the procedure. He also knows now that he did get the procedure, because 6 months later they were unblinded. So I think the next steps are these. Current levels of achieved denervation were probably suboptimal in this trial. Higher energy multiple electrodes are needed, but they're already there. Delivery of energy both proximally and distally. And this is the difficult part. So I think the technical advances are here, and we need to see more trials. But how are we going to assess the efficacy of renal denervation? And that's a weak point. It's not an angiogram where we can get an angiographic success. Norepinephrine spillover is impractical. We can't do it in everybody. ESLA is looking at urinary biomarkers of nerve degradation, purely investigational. Intraarterial adenosine is a marker of afferent nerve ablation, purely investigation. I've asked people where they're Holter monitoring looking at power spectra. I'm told that too much noise, it probably won't work. So this is a problem. I mean, how do we know if we have denervated? And it is one of the next steps to be addressed. And then we need to do a lot more work on specific subsets likely to benefit. And I suspect that the pathophysiology of hypertension with due deference is probably multifactorial, and there may be groups that benefit. So how do I think it's really all going to turn out? I think Mesli's editorial was excellent. The time has come to turn the page in renal denervation, but by all means, let's not close the book. Now, how do I think it's going to turn out? I'm really going to stick my neck out. Time will tell. I don't know. I'm fascinated by it. I find the whole area fascinating, and I wouldn't bet the mortgage, but I wouldn't write it off yet. Thank you.
Wonderful presentation. Any questions for Dr. Gersh?
Great talk. Could you speak to non-interventional approaches to denervation? In other words, is there any developments in demyelination drugs or any kind of strategies that would be more would take us away from the problems of targeting?
You know, the answer is I don't know. Usually when, somewhere along the line, ultrasound's going to make its appearance. But I don't know. Do you?
There are some non-radiofrequency ablation techniques with chemicals and things like that.
Yeah, that I've heard. But they're still going to require local delivery, I believe.
So Bernard, thanks. That was terrific. Including the stuff about, I think the most important things are probably about the sham, the importance of the sham and how maybe we were fooled. I think you're being a little too positive still about the promise of renal denervation. I mean, we always knew that the idea of substantial enough nerve traffic from the kidneys back to the body that would be suitable for radiofrequency ablation as a dominant factor in controlling hypertension. It seemed a little far-fetched, not impossible, but far-fetched. And then all the excitement was from these early uncontrolled trials, which used the same catheter that people are criticizing in the trial that was properly controlled that showed no effect. And you pointed this out nicely, I think. I guess the one thing that you highlighted was that maybe the investigators weren't using it. But I thought, when I talk to these guys, they say one of the beauties is anybody can do this easily. It's such a simple procedure that you don't have to worry about being. That's what they told me back when everybody thought that it worked.
And that's exactly what we were told before SYMPLICITY-HTN 3. So I think people are talking out of both sides. Maybe it would. Listen, I just don't know. I'm fascinated. That's why I find it interesting. I don't know. I think what I do know is we need to do the trials. I mean, I think we can't put it to rest on the basis of one trial. We need We need the trials, and I just don't bet on the outcomes. We will get the trials too.
It's a fantastic overview. Very interesting area. I'm curious, what your thoughts are about the placebo issue. We treat placebo as like the flies at the picnic, and yet we have so much trouble doing better than placebo. Are we just overlooking the thing sitting right in front of us that has pretty significant therapeutic effectiveness?
Well, what do you think, Dan? Back to you.
Well, you could say that that's what our forebearers knew and used very effectively. And I think, because we think we're scientific physicians, we're embarrassed to try to invoke the placebo effect.
I mean, there's that cartoon, I think it says, if you want to benefit, you've got to believe in it. And obviously, it plays a huge role. I mean, it does. You only have to look at the trials. I mean, Chris has just written an editorial for the New England Journal, and in that there is, look at the trials, what we call the indirect trials of coronary revascularization, internal mammary artery ligation, coronary sinus occlusion, ementopexy. What was the other one? The Weinberg procedure, asbestos in the pericardial cavity. Now, some of that may have been denervation. And in fact, people raised the question whether the relief from bypass surgery originally was denervation. But all of those trials had a great symptomatic response without any real physiologic basis to it. And so it plays a role. There have been a couple of trials that have really tried to look at giving someone a placebo, and they know it's a placebo, and they have not shown an effect. It's got to be in the belief that it works. This is a nice example. Find out who set up this experiment. It seems that half the patients were given a placebo and the other half were given a different placebo. Apparently that trial has been done and it wasn't effective. So we can't give placebos to everybody and expect a response. But it is a fascinating issue and very interesting.
My understanding is that this procedure, despite the data you demonstrated, is still being used in Europe.
Yeah.
A few other countries. What are your thoughts about that?
I think our FDA look good. They take a lot of criticism. I think they've behaved extremely well. They did not allow, I think this is what they mandated, and I think we criticize our FDA, and at times it is frustrating, and obviously with Rob Califf here, we were talking about it this morning. You know more about the FDA than I do. I think the Europeans are irresponsible. I think it's industry driven, and at least I would have thought they would put a hold on it. And I think we should have learned, maybe we have learned our lessons from PFO closure. 10,000 PFO closures in the US. We don't know whether it works. And now it's too late to do the trial, because the trials that were done, the problem was all those big PFOs in young people with cryptogenic stroke were now being closed, and we don't have the answer. And I think our FDA have behaved very well over this and very responsibly. And I honestly don't know how it's going to turn out.
I think you answered this already, but doesn't this make you really worry about so much of what we do in medicine that is based on clinical trials that are open label and don't necessarily assess hard endpoints, very hard endpoints? I mean, shouldn't this make us kind of relook at a lot of the evidence in more skeptical eyes?
Of course. And I think it still comes back to the issue of trials and registries, as you know so well here. They complement each other. There's a room for registries and there's a room for trials, and you've got to work out how to integrate the different information from both. But it does make one skeptical. And I think, really, if this is true, can you imagine a 30 millimeter drop in blood pressure with one little procedure, what that would mean in countries like sub-Saharan Africa, where I'm interested, where hypertension, or China, is out of control, and it's not easy to treat people. So it is a lesson for us. We'll see. I still hope that there will be subsets that can benefit.
Don't you think that the more experienced people are more likely to be more aggressive in ablating the tissue and more likely to achieve complete than partial ablation of the denervation, and therefore that may have been a critical factor?
I do, and I think that issue will not go away until it is more effectively tested in a trial. It's a point that they make. I personally, I think they protest it a little bit too much. As Chris said, initially we were told anybody can do it, and now we're told, you've really got to come from Melbourne and have to have done 50 or 60 of these. And no one has ever accused US interventionists of not being competent. We've been accused of being too aggressive. Competence has never been an issue, but it won't go away. And the data are there. I think it's a straw man, but I accept that it won't go away until it is tested.
Bernie, can I ask you about the rationale of doing a placebo-controlled trial on no meds? I was just pulling up a paper that Sana Al-Khatib and I wrote in 2001 about, it was a meta-analysis of a bunch of mild hypertension trials looking at blood pressure effect and the effect on clinical events of withdrawing people from antihypertensive therapy even for a short time. And I think it does get you toward answering the question, but because it's a more pure experiment that takes away one of the variables, but introduces some risk potentially for patients.
It does. It was an entire session of this FDA, American Society of Hypertension meeting. Entire session was on that, and people were very polarized. I mean, some people said this is totally and utterly unethical. Obviously, one has to be very careful. I mean, particularly if they're in beta blockers, no one's going to just stop it like that. It's, the drug washout period is going to take 4 weeks, and people have got to be under observation. I mean, obviously there will be some who become profoundly hypertensive, and one's going to have to be very careful. I mean, you yourself, John, know from here that in the trials of the novel oral anticoagulants and warfarin, the dangerous time was the changeover, as rocket and all the rest. So that applies here too. I think when you realize that just a huge number of hypertensives walking out there are not in any treatment at all, I think if they limited it to mild to moderate, apparently our IRB, which is pretty stringent, as is most, I think they're okay with it. But it's going to have to be done carefully.
One last question. So there's the intervention-related issues that Raj brought up, and you pursued a nice case of somebody who may have benefited. And Garen, I understand that it might just be sort of thinking about it, but any thoughts on pathophysiologic subsets who might benefit from this therapy in particular?
Well, I'd really like your thoughts on it. I mean, I think there is this group of maybe some of the white coaters who really seem to be sympathetically mediated. But whether we can, really let me ask you, I mean, do you think there's a way in which we can profile people according to their hyper-beta adrenergic status and that's the group who will benefit? I'm not sure.
No, I wonder if there's a way to look at some of the ABPM data and responsiveness. I'm sure that folks have tried to do that. I wonder if that would provide some of the information that might identify some subsets.
Maybe. Yeah.
Great. Well, thank you for a very stimulating and insightful presentation.
Thank you.